And what we will learn today: define rheumatic fever and rheumatic heart disease, describe the etiology, risk factor, pathophysiology, complications, symptoms of rheumatic heart disease, explain the management or in very short, nursing management, preventive methods. So diagnostic criteria, another part I just missed. Diagnostic criteria is also very important for rheumatic heart disease diagnosis. Revise Jones criteria that I will explain you later. So, starting, what is rheumatic heart disease? Rheumatic heart disease is the most common acquired heart disease in children, especially in developing countries like us. So, India, Bangladesh, Thailand, Taiwan, Southeast Asia, Sri Lanka, where the overcrowding is a problem, overcrowding is a big issue. These countries are commonly endangered by rheumatic fever, rheumatic heart disease like disease. So this is a chronic heart condition caused by the rheumatic fever that can be prevented and controlled. So the process starts from a sore throat. Better to say a sore in throat can break your heart. A sore in throat can break your heart. Not in that way. So rheumatic fever is an immunologically mediated inflammatory disorder principally caused by group A beta hemolytic streptococcal organism or Streptococcus pyogenes. Okay, so this is a multi-system disease involving heart, involving skin subcutaneous tissue, involving joints, and rheumatic fever, it's not a communicable disease, but the result from a communicable disease or communicable sore throat sequel. So sore throat or acute tender pharyngitis, this is the main insult that occur very long before appearance of the rheumatic heart disease, and rheumatic fever is the midway between acute streptococcal pharyngitis and the very later period rheumatic heart disease. So it's a crippling disease if it involves heart. The window period is very long, as because it may be 6 years to 10 years, the rheumatic heart disease may develop in a susceptible individual who had a previous history of sore throat or rheumatic fever in his childhood or in her childhood. So, epidemiological point of view, this cannot be separated. Rheumatic fever and rheumatic heart disease, diseases of the poor. So, most prevalent in underdeveloped like Kenya, Tanzania, Zimbabwe, like country, and developing country like us. Clinical course of rheumatic fevers involves a childhood infection that I told you earlier with complication in adulthood or cardiac defect. So epidemiology, 5 to 30 age group most commonly involved by rheumatic heart disease, and 12 to 65% of hospital admission related to cardiovascular death in developing countries. Okay. So in developing country, most people, middle-aged people, they come from the lower socio-economic strata. They often come to the hospital emergency with features of heart failure, and if dig up the patient by taking the history very meticulously, you will end up that there might be a sore throat or a rheumatic fever in her early adolescence or early adulthood. Okay? So in India, epidemiological data, not that much important for pathology purpose. So streptococcal infection common in children living in underprivileged condition. This is very important. Risk factor, age 6 to 15 years, untreated streptococcal infection. The streptococcal pharyngitis that has got very poor or very limited resources to treat it, this kind of untreated sore throat can lead to rheumatic fever and very later on rheumatic heart disease. Familial predisposition, now overcrowding, poverty, poor hygiene, as we said earlier, and lack of access to the medical care. Overcrowding, very important, because the sore throat in children of underprivileged area, they have crusted nose, crust in nose like lesion, and often they play together, the children play together, they eat together from common source, they eat, stay very close proximity. So it is very common in underprivileged areas or lower socio-economic structure where poverty is a big issue, where overcrowding is a big issue. So causes may be everyday oral activity. It may, the streptococcal infection can be inoculated through your dentist. If your dentist, for any procedure, whether it is root canal treatment or any extraction, if he doesn't or she doesn't follow the proper antiseptic procedure, it may end up to the pharyngeal streptococcal pathogens entry from your oral cavity, and finally they may lodge into your heart. Weakened immune system or infection, long-standing gum infection, long-standing purulent gum infection, pyorrhea, this kind of thing, if feel untreated, so it can also lead to the rheumatic heart disease. So just remind, a sore in throat can break your heart. So pathogen group A, beta hemolytic streptococcal pathogens. Okay, and the other infection caused by this organism, you know from your microbiology knowledge: scarlet fever, pharyngitis, acute glomerulonephritis, PSGN, post-streptococcal glomerulonephritis. Okay. So what is the pathophysiology? Immunological reaction, type 2, antigen-antibody reaction, immune response by B lymphocyte, anti-streptococcal antibodies, and finally these antibodies, they can cross-react the tissues of subcutaneous tissue, tissues of your heart, the entire connective tissue, and your brain. So there is a molecular mimicry. There is a molecular mimicry of streptococcal antigen and certain connective tissue component M protein in various parts. The protein or the antigen mimicry, it may be widely spread through our body, like in brain, in subcutaneous tissue, in all the joints. Okay. So group A streptococcal pharyngeal infection precedes clinical manifestation of rheumatic fever of 2 to 6 weeks apart. As I said, rheumatic fever is the midway of the spectrum, where streptococcal pharyngitis is on the earliest point or the starting point, streptococcal pharyngitis, then rheumatic fever, then finally rheumatic heart disease. Okay. So body produces antibody, cross-react with human tissue, antigenic similarity or antigenic mimicry. That is the basis of our knowledge of autoimmunity. What is autoimmunity? The antibody, the produced for the benefit of our system, eventually those same antibody are detrimental for our body because it has a similar antigen-antibody reaction towards our very known connective tissue like heart, like joints, like subcutaneous tissue, skin, etc. So immunologically mediated inflammation and damage, autoimmune. So this is an autoimmune condition. So clinical feature, sore throat, it can cause redness of the tongue, purulent tonsillar bed, white patches, crusted lesion in nose, tenders, cervical lymphadenopathy due to reactive hyperplasia. Okay. So painful joints, painful heart, painful skin, and painful chorea or nervous system involvement. So these are the clinical manifestation of sore throat that you need to check, and you need to treat it accordingly and vigorously so that the complication from this sore throat, this merely less important sore throat, can eventually damage your heart or damage your joint. So gold standard of diagnosis is positive throat culture with help of Department of Microbiology. positive throat culture of the swab. Okay, tonsillar exudate, excoriated nares, strawberry tongue or red tongue, tender tongue. More commonly in winter and rainy season due to more overcrowding, more dust in the air, more allergic individual come to the place and gets the system very unhealthy for overcrowding. So this is clinical feature of rheumatic fever, shortness of breath. If it occludes the oropharynx, it may obstruct the air entry and can cause dyspnea or difficulty breathing, shortness of breath. So features: following upper airway infection of group A, streptococcal infection, silent period of 2 to 6 weeks, sudden onset of fever, pallor, malaise and fatigue. That is the clinical features of rheumatic fever. Commonly group A streptococcal infection is subclinical, such as confirmed using streptococcal antibody testing or blood culture or antibody determination by microbiology department. So there is no definite test. A group A beta hemolytic streptococcus may or may not damage the heart all the time, because many of us can get any streptococcal infection throughout our life, but all the streptococcal infection doesn't end up to the damaging heart and damaging our joints. So there is no definitive test. So what are the tests? What are the points in favor of diagnosis? Few criteria, few combination of clinical symptoms, few clinical pictures. We have to permutation and combination add up with some lab feature. Then we come to the diagnosis that finally this patient is probably getting a rheumatic heart disease. So coming from this uncertainty, Duquette-Jones in the year of 1944 probably he come up with an idea, or he come up with a diagnostic spectrum. So he enlisted few criteria, few clinical symptoms as major criteria, few clinical symptoms as minor criteria, few lab feature as minor criteria, and finally come with the concept that how the rheumatic fever or rheumatic heart disease can be diagnosed. So now what we follow, that is modified Jones criteria. Original Sir Jones, he developed the idea, so he was the pioneer of that thing, but in later on with the advent of medical treatment, with the advent of medical diagnostic, few more criteria both in clinical and diagnostic laboratory parameters have been added to the criteria, and this is now called revised Jones criteria, very important for your short topic. So major criteria: joint, that is migratory polyarthritis. What is migratory polyarthritis? That it involves the joint, it swells the joint, pain, swelling, tenderness, warmth, everything happens to the joint. The patient is distressed, but surprisingly, those affection to the joint, those affection to the larger joint of our body may subside, or usually subside after 3 to 5 days or 5 to 7 days. And surprisingly, another next adjacent joint affected by the same organism. So this is called migratory polyarthritis. It mostly involves the larger joints of our body, like shoulder, like heel, like knee, like elbow, larger joints of our body, and this is migratory in type. Tale, if any patient comes to you with joint pain, you must include a point in your history that whether the joint pain migrates, whether the joint pain confined to one joint, or the joint pain migrates to other joints and leaves the joint, leaves the previously affected joint as it was before. So migratory polyarthritis is very distinctive portion of this major criterion. Now carditis. So when coming to the rheumatic heart disease carditis, you just remember one word, that is pancarditis. Pancarditis. Pan means global involvement, Pan Asia Kitchen, Pan Pacific Airlines. So pan means global, or it involves the everything. So pancarditis, the three layers of our heart equally involved, or sequentially every layers of the heart is involved. Endocarditis, that is the inflammation and affection of endocardium. Myocarditis, that is involvement and affection of the myocardium. And finally, the outermost word, that is pericardium. So pericarditis also there. Shaggy pericarditis, fibrinous exudate, fibrinous pericarditis. So endocarditis plus myocarditis plus pericarditis is equal to pancarditis. So pancarditis is the distinctive feature of rheumatic heart fever or rheumatic heart disease. So various clinical manifestations of heart failure like murmur, mid-diastolic murmur, systolic, pansystolic murmur, S3, S4 sound, we usually auscultate the patient when S1, S2, lugged up. But in the patients of heart failure, we may also get the S3 sound and S4 sound in very experienced ear, actually. So, next is nodules, subcutaneous tender nodules. Presently, mostly on your dorsal aspect of the body, that is shin bone, dorsum back, just below your elbow. So, dorsum aspect or extensor surface most commonly involved and late manifestation, non-tender subcutaneous nodule on bony prominences. Okay, so small, painless, mobile, hard lumps beneath the skin. And most common, as we said, extensor surface of joints and knee, pinhead to almond size. Now, these are the picture of subcutaneous nodule. You may get this while you travel, while you visit a patient or your ancestral home. You may see this, very common. So, this is subcutaneous nodules. Can everybody see the picture? Definitely yes. This length of this auditorium is too short. And another major criteria is erythema marginatum. Erythematous serpentinous lesion that commonly affects the trunk, and this is also the skin and subcutaneous tissue manifestation of rheumatic fever. So this is early manifestation, erythematous serpentinous non-pruritic macular lesion, pink macules may be serpentinous spreading edges of the body, more common in trunks and leg, almost never on face. So rheumatic rashes or erythema marginatum, not common in face. But what rash is more common in face? Anybody? What kind of rashes is more common in face? Yes, systemic lupus erythematosus, malar rashes. These are commonly present on face. And it originates application of with heat and often associated with chronic carditis. So joints, so then carditis, then subcutaneous nodule, and finally erythema marginatum. These are all major criteria. So this thing, one or more, must be present if you have to diagnose or arrival at the diagnosis of rheumatic heart disease. So this is erythema marginatum. Serpentinous, like a snake, not like a snake you encounter in your hostel. Another syndrome chorea, involuntary jerky movements of extremity due to involvement of brain, that is syndrome chorea, exacerbated by stress and disappears with sleep. Okay, milk-made pain, handwriting examination are two important bedside method to diagnose syndrome chorea. Okay, it is self-limiting, and syndrome chorea may come with complications like symptoms like disturbing speech, blurring of speech, disorientation, etc. And minor criteria: fever more than 39 degrees Celsius, last about 12 weeks, tends to recur, weakness, malaise, weight loss. So, coming to the minor criteria, most important is fever. Then arthalgia, minor criteria: epistaxis, abdominal pain, high ASL, anemia, leukocytosis, high C-reactive protein. These are all minor criteria. Elevated anti-streptolysin no antibody, ASO. You often get in your laboratory, clinical laboratory practice, that high ASO, 600, 700, 1200, 3000 ASO. Maybe the antibody that occurs very early age of life, still maintains its titer to the high level. ECG, prolonged PR interval due to carditis or pancarditis. Throat culture, positive, group A beta hemolytic streptococci. So, for the diagnosis, what I said earlier, for the diagnosis, you need two major plus essential criteria or one major, two minor and essential criteria along with evidence of streptococcal infection. So, what does revised Jones criteria say? If you want to arrive at a diagnosis of rheumatic heart disease, you must present two major criteria and one minor criteria in the patient, or one major, two minor plus essential criteria along with positive throat culture with beta hemolytic streptococcal infection evidence. So this is absorption, generally present in myocardium, immunologically mediated action, deposition of antigen-antibody complex in myocardium due to molecular mimicry of cardiac M protein with streptococcal antigen. So the body recognizes the heart tissue as a foreign body, as a thing to be killed. So the insult occur, and Aschoff cell very rarely found nowadays because you can't get a biopsy of heart until you are dying. Okay, so this picture is very rare to get nowadays. So revised Jones criteria we told earlier. So treatment of rheumatic fever, that is prevention is better than cure, or destruction of the killer at the very same point of entry at very earlier stage. Oral penicillin or injection of benzathine penicillin, IM, very painful to the patient. Benzathine penicillin, intramuscular route, erythromycin tablet can be given, and the patient should be started on long-term antibiotic prophylaxis. I remember from my internship days or my college days, one girl, she was very attentive, she was very disciplined. She used to come every single week in Arjikar Medical College to take the benzathine penicillin intramuscular dose. Her mother was crying due to intense pain to the patient, but the patient, the children, nearly about 14 to 15 years of age at that time, she consoled the mother, this is a phenomenon of every month, ma, no need to cry. So, disease make you mature. So, patient should be on long-term antibiotic prophylaxis therapy if you don't want that any dreadful complication may arise to the patient. Arthritis, arthralgia, salicylate, NSAIDs, aspirin, atorecoxib, very useful for the joint pain, arthralgia, migratory polyarthritis episode. Severe carditis, dexamethasone, prednisolone, corticosteroid, very important for treatment of severe carditis or pancarditis. And the drug of choice on syndrome Korea, MCQ that used to come in our times, haloperidol. Drug of choice in syndrome Korea, haloperidol, but diazepam, levetiracetam, this group of drugs may be used. So, prognosis of rheumatic fever can recur whenever individual experience new group A beta hemolytic streptococcal. As just because you encounter the dengue season, dengue episodes, the second time dengue infection is very dangerous or more dangerous than the first previous one, because the new antibody formation, new kind of cross-reactivity reaction, this can affect the health more severely than the initial first episode. So, it may recur. Good prognosis in older age group if no carditis during initial attack. So, and it is very bad prognosis in younger children and those with valvular lesion. So, rheumatic heart disease, most important, there is valvular lesion. Okay. So, what are the clinical manifestation or affection in rheumatic heart disease? Valvular damage. So, how many valves we have in our heart? How many cardiac valves there? So most commonly involved valve is mitral valve, drain tricuspid, then aortic, and least is pulmonary. Why? Because it has direct connection with the oxygenation source of our body. Okay. So permanent heart valve damage resulting from one or more attacks, and if rheumatic heart disease can go undetected, with the result that patient present with debilitating heart failure and ultimately unfortunate demise. So mitral, aortic, tricuspid or pulmonary. Pulmonary is the least and most common is mitral. So damage of the heart valve in form of vegetation, in form of thickening of valve leaflet, in form of adhesion of the valve leaflet. Okay. Valve incompetency, more common than stenosis. So regurgitation is more common than stenosis. Okay. So this is an affected valve. This picture is very hard to get, except you are getting picture or getting specimen from your post-mortem area or morgue area. Okay. So this is a damaged valve. You see, there is thickening of valve class, this commissure is thickened, and there is decrease in caliber. Okay. And most important part of this involvement is thickening. So pathophysiology, group A beta hemorrhagic streptobronchi, untreated sore throat by streptococcus, rheumatic fever, all layers of the heart of valve become inflamed, as the term is said, pericarditis, vegetation forms, valvular regurgitation and stenosis, and finally heart failure. So please see the difference of unaffected valve and the affected valve. So normal valve looks like a slit, just opening that allows flow to one side and blocks the flow to enter from other side. But in case of rheumatic fever or rheumatic heart disease, thick, fibrous, scarred, stenotic and fixed. So there is limited mobility with the blood flow, limited mobility, limited movement, and finally comes with the patient of the problem like valvular regurgitation, okay, or incompetence. So what we get, the patient to the heart failure, high pulse rate, hyperdynamic pulse, prolonged PR interval in ECG, S3, S4 sound, okay, ECG te heart failure pabo, pericardial friction valve, very important for the patient of pericarditis, okay, cardiomegaly in X-ray, myocardial involvement and murmur when auscultation is in process, S1 and S2, this within this gap, you may heard a murmur. Have you listened to murmur someday? Anybody in your world? No murmur. Okay, you will get in your clinical posting that the